Well, welcome back. Appreciate everybody spending the time yesterday. Hopefully you had a good evening last night. So it's my pleasure to welcome you back to this second day of the Region 7 APHA meeting. Don't we have great weather? I mean, boys, somebody needs to really take credit for the weather that we're having. It's really, really outstanding, and maybe appropriate too, since we've got folks from more southern climes than ours coming. It's a little warm for spring in Iowa, but nonetheless it's useful for getting outside and really enjoying things. So today's opening session includes representatives from our federal partners, which I'm very excited about. We all know and understand and appreciate the importance of the intergovernmental interdependencies that we have in public health. The roles of local governments, state governments, federal, and the federal government, the relationship, the expertise, the sharing of resources that we engage in are all absolutely pivotal to improving the health of Americans. And so it's in that vein today that we welcome our Corstella, our Region 7 office rep, and Dr. Montero from the Centers for Disease Control. We're thrilled about them both being here today. And I've got the honor of introducing them to you, and I'm going to introduce each of them individually prior to their remarks. And so I'm going to start first with Dr. Montero, since he's on the agenda first. So I'm going to read a little bit of his bio. Dr. Jose Montero serves as the Deputy Director of CDC, responsible for overseeing the U.S. health departments, the tribal nations, insular areas, the state and territories. As Director of the Center for the State, Tribal, Local, and Territorial Support, I know this is O-stilts. And I have to say, I noticed that it says center and not office. Is that a change?
We're in the process.
Okay, very good.
Almost there.
So C-stilts. You're gonna coin a new abbreviation.
Sounds like a medical.
Dr. Montero oversees key activities and technical assistance designed to improve the public health system's capacity and performance in an era of healthcare reform. Previously, Dr. Montero served as Vice President of Population Health and Health System Integration at Cheshire Medical Center, Dartmouth, Hitchcock, Keene. Prior to that, and for 7 years, Dr. Montero served as Director of the Division for Public Health Services at the New Hampshire Department of Health and Human Services, and that's the period of time that I got to know Jose as in his service as State Health Officer in New Hampshire. In that role, he led the delivery of high-quality, evidence-based services and prompt response to public health threats and emerging issues in the state. Dr. Montero has extensive experience in public health leadership and in the prevention and control of infectious disease. His major research interests includes vaccine preventable diseases, epidemic preparedness and response, and the integration of public health and population approaches into clinical practice. He has held many national and regional committee leadership positions. I can't possibly go through the entire list, but I do want to hit some highlights. I got to know Jose in his role as president of the Association of State and Territorial Health Officials, ASTO, my peer organization across the country. Jose also at one point chaired their Infectious Diseases Policy Committee, so he's been very actively involved in ASTO. He's worked closely with CDC previously as a member of the Board of Scientific Advisors for the Office of Infectious Disease, the Social Determinants of Health think tank that's a part of a subgroup providing advice to the Director of CDC, and also on the CDC Advisory Committee to prevent tuberculosis in healthcare settings. He's, as I mentioned, served on a number of federal and other national organizations such as ACIP, NASHB, too many abbreviations, and the IOM Roundtable on Population Health. I came to know and appreciate Dr. Montero's expertise and leadership as a result, as I mentioned, of his work with ASTO. I very much appreciate his advice and his friendship, and I'm thrilled to have him in Iowa. This is his first visit, and so we've got outstanding weather and good topics to talk about. So join me in welcoming Dr. Jose Montero.
Thank you very much. Good morning. Sorry, I already had 2 cups of coffee and it shows. Normally I don't stand still. I have a hard time staying put, which is not new, but Everybody knows what CDC is. It's the Centers for Disease Control and Prevention. Most of the time we assume that it's only one organization, but actually no, it's not. We are a conglomerate of different centers of expertise that provide a lot of the technical expertise and, and technical assistance within the public health enterprise around the country. And not just around the country, but actually even around the world. We're not that old, actually. And we are part of the big HHS family. We are the major federal agency that is not headquartered in Washington. We're in Atlanta. At the beginning of the times, in 1946, somebody donated some land and the university put some work in infectious diseases. Actually, at the beginning, CDC was communicable disease control or something to that end, and it evolved. Now we are close to 20,000 people, 12,000 of us, maybe full-time, and a lot of contractors. A lot of MPHs, PhDs, and MDs. It's a really powerhouse of scientific capacity, and hopefully we provide all of these 6 things that you see there to you in a regular, normal, and accessible way. So most people, when they think about us, you think, oh, CDC, so flu, oh, CDC, Ebola, oh, CDC, and that is actually the general perception of the public. We have even measured that and asked the public and the elected officials what they think about CDC, and most of what they realize about us is emergencies and infections. When we start to talk about other stuff like obesity or behavior, yeah, you, what? There is not that level of knowledge. And I guess that you who are engaged in public health in this area, in this region, realize that when the public talks about public health, it's not talking about what we talk when we are talking about public health. And that's something that we need to figure out way better than what we are doing right now. We do a lot of communications and guidance around public health things and trying to provide that scientific backbone for the system. At the same time, we try to explain what public health is and how big and far our role goes. Sometimes people don't understand that now we have an Ebola problem in Africa and we had to send people there and we are working on that, and that we have a volcano in Big Island and we are part of that response, and we have not finished the responses in Puerto Rico. So how do we communicate all of that and provide the right guidance that you need? At the same time that we are supporting you and working with you in doing surveillance and keeping track of what's happening. I know I had coffee. I just talk fast normally. So if because this mix of speed and accent is killing you, let me know, and I'll say something and I'll keep doing it because I cannot change that. So we need to do that. So this partnership with the locals and with the states and with the regions and how do we respond is incredibly important so we can do the proper epidemiology and surveillance. In many cases, we collect information directly, but most of the time, information comes from you. People will complain, CDC didn't have the right information. Guess what? Who didn't give it to us? Yeah, the Iowa Public Health Director or the Nebraska one. Let's use somebody who is not in the room. I know that you are recording this. What I just said is not true. We have an awesome working relationship here. But as I just mentioned, Ebola, clearly our role is global. We need to be able to stop diseases before they come here, just for self-preservation. But at the same time, when we look at our role as a country and as a nation around the world, certainly we should be there supporting and preventing those things from happening. Clearly, we do a lot of innovation in science and new technologies. Maybe you saw a couple of days ago, we released a new rabies test that will speed up the capacity of what we do testing animals. So it may be that we decrease the amount of people taking shots for rabies when they get bats and in the rooms, which brings to this other component of the laboratory diagnosis piece. So certainly we do prevent, we do detect, we do respond, and we all do all of this from a science perspective. We have a new director, and I am a bureaucrat, so I need to show you an org chart. So just go with it. So we have the director, and we have a lot of people. So when we talk about centers, this is what we're talking about: the National Center for Immunizations, the National Center for Emergent Infections and Zoonotic Diseases, the National Center for HIV, the National Center for Chronic Diseases, because those are our national reference centers. So when we do that, each one of these centers has a level of expertise. But how do we cross-cut things? Well, we are not necessarily as good as we want to be in the cross-cutting thing. So these groups that we have here try to help to do that. My office, by design, have to bring together many of these things from across CDC, and I will show you in a few minutes. While talking about the new priorities that we have, the new director's priorities, which become the agency priorities, I'll show you how we are trying to build that connectivity. So as you see in this slide, our new director has highlighted 4 big areas where he wants us to emphasize. This doesn't mean that we are not going to work in everything else that we do, but given the fact that the perception around what we do is a lot tied to this, it's good that we can highlight those. But when you think about it, opioid addiction is kind of the epidemic of our times. Global health and global health security is something that clearly is part of our mission, of our core, and we need to do. But this next one is an interesting language. Why aren't we talking more about eliminating diseases? Now we have a cure for hepatitis C. Now we can stop the spread of HIV with PrEP and early detection and many other things that we have. Why aren't we looking at that as the message and actually move into planning for that and clearly improve the quality of our healthcare delivery in many different areas, including antibiotic resistance and antimicrobial and antibiotic resistance. When you look at these things, there are a couple of subtexts there. We need better data and more timely data. And we need to be able to better work with the healthcare delivery system or the disease care delivery system, whatever way you want to call it, and including not just the medical piece, but the behavioral piece as well. But this is what is funny about our federal government, and we are the feds, so we cannot come and tell you. I told Gerd, and this is true, I cannot come if I am not invited. I'm a fed. So yeah, I am here to help you, but you don't want me to help. So I have to wait for you to call me type of thing. But when we look at this stuff, clearly from the federal level, we can set up the policies that allow you to be successful. By we, I mean or Congress or some regulations through what we do in HHS in the big family. So Medicaid, Medicare are the biggest payers, so clearly we have a lot of capacity to move things there. So global health used to be in some point that we couldn't care less, right? Because it was far away and it was never going to get to us. Well, that's not true anymore. We know the airline patterns, how quickly we get infections around. The best example for that that we have in recent history is SARS. Like when 10 years ago, 15 years ago, some guy got sick in one province, went to Hong Kong, and Hong Kong infected people from 14 countries. In 3 weeks, we had a worldwide outbreak. Montreal, Toronto lost $7 billion because they had to shut down the city. It wasn't Ebola. It was SARS. So stuff happens. So we need to figure out how to do that. Clearly, we are engaged in whatever response, you name it. The most recent ones, Zika, polio, we are still engaged at some levels in Flint. Now, let's go back to the director's priorities, and I'll walk through. I used to be an epidemiologist in a previous life, so I use a lot of data, and I have like 500 slides. And most of those, I'm serious. I'll try to go quick through some of those. But in some of those, I want to highlight a few things. So we want to control or eliminate HIV, right? So where do we go? Well, we need to go where HIV is. If you look at the rates in this neighborhood, California, 376.4. Where is Florida? They move it. It's in this corner. 615. Georgia, 588. New York, 768. Where is Iowa? They still have it here. 93. Missouri, 234. Nebraska. So what this big difference in this region, we need to better understand those things. We need to better understand who those are. But clearly, if we're going to get a bigger impact nationwide, we need to work here. We need to work here. We need to work here. We need to work here in this 500. We need to work in these ones without abandoning the other part. So how do we create programs that work for all of us when our epidemiology is so different and the dynamics of each state are so different? So clearly, just one approach for everybody doesn't work. The populations at risk in every state are different. When we look at who is infected, we have actually a good success story. We have a 56% decline between 2008 and 2014. Now, look at 2014. I am not talking about the Indiana from 2 years ago. I'm not talking about the other outbreaks that may be IV drug related. But we got a 56% decline among people who inject drugs, HIV transmission. Why? Because we have syringe exchanges and many other things. 36% decline among heterosexuals. 26% decline among gay and bisexual men between 35 and 44. And just 18% decline in the younger crowd. But when you start to break that down, you see this. Everybody else is going down except this group. We need to do something about the increase in HIV transmission in young African American men who have sex with men, because we are seeing an increase there. So how do we target that particular group? Where are they? How do we work with them? We need to figure it out in each one of the different regions that we are. The other thing that if we are going to really be talking about HIV and AIDS control and elimination is how do we do this early detection? Most of us in this room may go to the doctor. Many of us may or may not have the same risk factors. Many of us may have higher level of risk factors for HIV, but not everybody who has a recommendation from our scientific approach to be tested gets tested. Why? Why can't we get clinicians to test people? So we detect them early. So 7 in 10 people at high risk who weren't tested for HIV in the past year saw a healthcare provider during that time. So when you look at what I said earlier, that we are going to talk about HIV elimination, we cannot talk about that if we are not talking about how do we connect with the clinical system. We can talk as much as we want and campaign and draft pamphlets in public health. We don't get the doctors to test. This is not going to change. This is not going to change if we cannot improve that type of working relationship with them. Half of the people that gets diagnosed with HIV have been living with HIV for more than 3 years. We are getting diagnosis late. We have PrEP. For those at high risk, we can give them the thing, and they will not be infected and they will not spread it. And today we have treatment that gets people to not have viral exhaustion. So we can have prevention of transmission by controlling those who are sick, because we can get them to not have the virus circulating, and we can prevent the infection in those who still have the high-risk behaviors using PrEP. We don't deliver those necessarily in public health. Not every state now has STD clinics. We don't do that. But clearly, we need to get to work on those and identify those high-risk groups. And as I said earlier, the group where we see the increase. Same thing with hepatitis C. Now we have a treatment. We have a cure. We can cure this thing with 4 or 6 months. I don't remember. I'm not a real doctor anymore. I don't see patients. But we can treat it. Now, can we treat everybody with a treatment that is $100,000 a year? No, we can't. Can we with $80,000 a year? No, we can't. Now it's around $50,000. Can we do that? Maybe we can't. It's a truckload of money. Now, still, when you look at this from the cost-benefit perspective, we know that even at that price, the return of investment is there. So we need to be able to figure out how we get to the political level where the decisions about funding are made and get this to work. Now, there are awesome examples from other countries. When you look at Australia as an example, they were able to negotiate with the pharmaceutical companies and got the hepatitis C treatment for $7,000. They now have correctional facilities that don't have hepatitis C. When you look at your correctional facilities, you know that your rates are 20 or 30%, depending the correctional facility. These people get out, and they go and use drugs or engage in other activities within their community. That is where we keep getting it. So we need to figure out all of this so we can really change the dynamics in hepatitis C. While we are looking at that, then talk about sex. Well, I'm not talking about sex. I'm talking about sexually transmitted infections. And something that has been happening is what you see in this particular slide around congenital syphilis. And you start to see here the connection. Who gets more syphilis? Well, clearly men who have sex with men, but heterosexuals do too. When you have heterosexuals having it, then you get women. When you get women, boom, you have this. So how do we look at STIs and the connection with our maternal and child health programs? In many states, they don't work together. Maternal and child health programs used to be the crown jewel of our health departments. And now that we have been so successful in decreasing maternal mortality and even decreasing adolescent pregnancies and all of these things, they are kind of fading into the background. Unless we engage with them, learn from their tools, and bring up all of what they are doing so we can target the populations that are at high risk, which are not necessarily this neighborhood. But again, look at Florida, look at California, look at Texas, Louisiana. So what's the issue there? Is access to care? Is insurance? What is it? How do we look at those and identify the population that have the higher level of risk? Clearly, when we look at this type of stuff, we know that it's tied to poverty. We know that it's tied to populations who have less access, who have less education. So how do we change that? You know, there are many disparities in those diseases, and we are going to eliminate them. But we need to understand that disparities are not inevitable. We need to identify what is there and target our policies and our actions toward those groups. Having a generic HIV prevention program for a whole population is a good thing, but I wouldn't put all the eggs in that basket. Because maybe people like many in this room are not the target for a high-risk behavior. And we need to emphasize and work with those who don't have the same level of access to education as we do have. We need to work in this together and create a comprehensive thing. Now, I'm going to show a couple of things that are not in the list of priorities to highlight that regardless of the fact that we identified those key priorities that I showed you in the first slide, we have some other things that we're going to be working on. So the National Center for Immunizations and Respiratory Diseases is where we have all of the vaccines. Vaccines are one of the most successful strategies that we have ever had in public health. And we have been so successful that now people don't see the need for them. You know, it's like the maternal and child health programs. You are so successful that then what's next? And none of you ever saw a patient with diphtheria or polio or one of those. So how do we manage and educate our public toward that? There is a lot of vaccine hesitancy. With those groups we can work. There are some small minority of vaccine deniers. I don't think that you're going to convert them. So work with the hesitancy groups because they still believe in the vaccines. They just need some better education. So we are talking about disease elimination, HPV. The rates of that vaccine are not as good as we need them. But as you know, we are changing the dynamics of cervical cancer because we are using that particular vaccine. And as you well know, that is a cancer that is tied to socioeconomic status. We need to change that dynamic. We need to work in a couple of things around that. So this is the 100-year anniversary of flu. We need a better flu vaccine. We all know that. A lot of people are working on that. In the meantime, we have to work with what we have. And the rates of vaccination with flu show clear disparities. We are not getting to all the groups that need to get them. Those with chronic conditions that have higher level of risk and are in the pockets of poverty are going to continue to suffer more unless we are able to figure out how to better engage them. We're going to continue to work in obesity, tobacco, cancer. Those are clearly things that we cannot not work on. We have been, until now, quite successful with tobacco. We are at the time of a new switch and paradigm with the e-cigarettes and all of those new things that are out there. And you saw the data. We published the data not long ago. Big increase in the teenagers using that, and a dramatic switch between those who start with e-cigarettes to use real tobacco products. We cannot allow us as a society to go back to that. Should not. Now, we have a National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry. Sometimes I forget the ATSDR. I am bad with acronyms. And that's a group that allows us to work in asthma, to do environmental health tracking, those grants that most states do have. And we will continue to work on that. But when you look at that environmental component, and the reason because I had it there is that it ties to what we are talking when we're talking about chronic conditions. To improve outcomes in chronic conditions, we need livable communities where we can better walk, engage, exercise, be more social. Those are the things that are going to change what we do in those diseases. Then now the injury component. For CDC, all the work in opioids prevention is part of the Injury Center. When you look at the federal structure, you have the Substance Abuse and Mental Health Agency, which has the lead on that. You have HRSA, who provides a lot of funding for this. You have several others. CDC's lane in this has to do more with the surveillance and some of the education that we are doing with prescription drugs. So we all have seen this graphic. It's amazing. We saw it. We still see it. We are starting to make some changes there. But most of the time, the attention goes here. As every time you look at the top of the pyramid, right? Oh, look at beauty. And we forget this part. We all do that. We all do that. But for every person who died, there are 18 people who have a substance use disorder involving heroin. There are 62 people that have an issue with prescription drugs. There are 377 people who misuse prescription drugs. So as much as I believe that we need to put naloxone in the streets, I need to work here because if not, I am never ever going to change this. So we as a system need to be able to do that because then we have almost 3,000 people who use prescription opioid drugs in the last year, and we don't know of those. Well, we know one of them is going to misuse it. And then you start to look at the progression. We need to figure out how to work upstream. So when we are looking at people who use prescription opioids in the last year, were all of those necessary? Did they get the right prescription? Did we give them the right amount? Did we get the right substance? And that's something where CDC has done a lot of work because we wrote the guidelines for opioids management. And we are trying to help keep track of all of those through the prevention drug monitoring programs. But we need those programs to talk to each other. Each state has one, but if you don't talk to the next state, the drug shopping and the doctor shopping goes around. Now, I know that the dynamic of that has changed because at the beginning it was only prescription, but now people can just get those in the street coming from everywhere else without a prescription. So we still need to do what we need to do. We still maybe are prescribing too much. Justice Department or police agencies will have to figure out how to stop the influx of the illegal drugs. But then what we're trying to do is help work with the state health departments and other agencies in the state to build that capacity. We are trying to support the providers and work with the payers to figure out how to better improve and provide access to other things that will allow better treatment of pain without having to use opioids. Clearly, we need to partner with public safety, and we need to empower the consumers to make safer choices, and that's something where we, the big public health system, needs to figure out how do we educate ourselves to better understand that not every condition requires medications. We as a society think that everything requires a pill. And I am a family physician by training. So yeah, I did prescribe a lot of stuff, and when I think about it today, did I prescribe? Hopefully I didn't get anybody hooked on anything, but you never know. But we as a society assume that everything is going to be solved with a pill. We need to figure out how do we change those dynamics, including ourselves, because we are part of it. And clearly we need to keep track of what's happening. As I said, we have this good awareness campaign. But something else that we need to do is we have better data. Remember in the first slide when I was talking about the need for data? Well, you guys in every state, in every city, you do the vital records. You get the birth certificates and you get the death certificates. Our goal is to get 60% of the death certificates within 10 days. So when you are trying to figure out how many people died when overdose last week, if we don't get death certificates, we don't know. And look at the lag on this. So up to last year, almost half only came within 10 days. We need to improve that system. So how do we do that? Working with the physicians, but we need to work with this other interesting partner for public health that is called funeral directors. When they check those things, they don't tell us if the person is white, African American. They don't tell us if it's Hispanic. We have no idea who is Native American or Alaska Native, because those boxes are not filled. So when people ask me, what data you do have about minorities? Well, sometimes we don't have it. Why? Because you don't give it to us. I love blaming somebody else for something. Final, because you will give me a hard time later on being a Fed, but I'm putting this one here. So the timeliness, so it is improving, but we need to do more. Now, I'm going to show you something quite interesting. So look at the year. So this is overdoses, death rate per 100,000 people. Red is bad, and this is not a political statement. Don't get me wrong, I didn't come to tell you anything bad. So in this particular, because the rates, higher rates are red. So look at the year, 1999, 2000. You see how the blue disappears. It's like the political map, right? 2002, you start to see some other red spots. 2003, 2004, 2005, 6, 7, 8, 9, 10. Tell me this is not the epidemic of our times. We have seen it in the last 15 years, dramatically change. This area still has blues. Look at the rest of the country. We almost don't have it anymore. Look at the rates. So we moved from 2.3 to 2 to 3.9 to over 30. That's opioids. That's heroin. That's methamphetamines. That's drugs. So not a single organization is going to be able to do a single change that will change this dramatically. Unless we are all together with the same goals and identifying what the specific role of each one of us is, we are not going to be able to change this. One advantage that we have today is that the early profile of those dying with opioids epidemics change. Used to be that them were the ones dying, so we didn't care. And you know who them is. With the opioid prescription, the population changed. So we start to overdose. That became a problem. Let's use it. Let's highlight the fact that drugs affect us all. And that increases the risk for us to get HIV. It increases the risk for your child, for your grandchild, to be born with neonatal abstinence syndrome or with congenital syphilis. And you start to see the connection between all of these different priorities. We need to be able to tackle and identify those different components and get those to the right population and the right advocacy group and identify how this builds in the whole mission of what we need to do to improve the health of the population that we serve. When we look at this from the perspective of only minorities, in CDC we have an Office of Minority Health that is trying to help us figure out for all of these different areas how to reduce the health disparities. The HIV STD group has done a fantastic, amazing job. They even published all the data that they identified in social disparities and social determinants of health as they relate to STIs. You just go and look at our infectious disease journal a couple of years ago, and you have all of that there. Certainly, we collaborate with everybody who we can to do that. We have identified a road, a path to health equity, which requires us to have better designed programs, but requires us to better measure and record the right type of information. And if we don't even have it for the birth certificates or the death certificates, we cannot properly calculate and design the programs as they need to be. And then we are the executive branch of government. We are not the legislative branch of government. Sometimes people tend to forget that. We don't decide our budget. Our budget gets decided for us. So we implemented programs. But we need to be able to talk to those who decide policy and engage with them. You know what I'm talking about? I'm not asking you to do anything that I shouldn't ask. Because we don't lobby, we inform people. I am not asking you to do anything like that. So clearly we need to better work with public health and healthcare. We have developed really good guidelines. We even identified six things that clinical systems really like to work on, and the payers too. And that's beautiful because then we can identify the right type of payments. And if the payers are paying, then we can have the programs. Of course, we need the people that we need to have access to the program to have health insurance or access to the healthcare, and that's a whole different animal. But at least we have identified this, and we identified policy interventions that will change the environment that we need to change. So we have all of this data in our website. The high five is health impact in 5 years. We spent a year and a half reviewing this to identify things that will be helpful to you. We know that political cycles run in 2 to 4 years. So it's hard to talk to a governor, to a legislator, to a congressperson and say, hey, you're going to change this for 20 years. No. I know that's the right thing to do, but we need to live in the real world. So we identified these high fives. So where we can measure the return of investment of these different things. So this is science. And we have that science there, and we can use it, and you should use it. Somebody said, talk about money. I said, I don't talk about money. It's in bad taste. My mother told me, as a physician, I could never bill a patient. They asked me how much, I don't know. Go and talk to the desk, right? So this is our budget. The last couple of years, 16 and 17, were kind of the same. This year, fiscal year 18, you see a big increase in CDC's budget for the first time in decades. This is kind of an artifact. I won't go into explaining that. A lot of what is here is opioids, which is new funds, and $300 million, $400 million for a new BSL-4 lab. So yes, we did get an increase, but the increase are tied to specific things. This is the administration's proposal for next year's budget. So what do I do? Nothing. I am just the head of this office. We are trying to change the office to be a center in the same structure of everything else that we have at CDC. But our goal is not a disease, is not a risk factor. Our goal is to have better public health systems. And that is what the center that I am the director for right now, proposed director, proposed center, proposed something, mission is. So we need better systems. We will not eliminate HIV. We don't have a system that is able to cope with the maternal issues, the sexually transmitted issues, with the drug issues that are tied to HIV. So we cannot look at things only from the perspective of one disease. We need to look at this in an integrated manner. We provide technical assistance. We work with the health departments to help them develop the system that will improve their performance. We place people in the states. We have 3 public health associates here who are early career people that CDC hires and places around states or local health departments or nonprofits, as is the case here, that have applied, that help us build capacity and create the next generation of public health people. So how do we do that? Because, well, of course, I have all the best ideas in the world. You know, I am brilliant. But the reality is, no. I ask. So I go to meetings and I ask people, so what is missing? What should we be doing different? Beyond the money, and you saw the budget. So beyond the money, and even if it's the money, what information do you need to do your thing? Whatever that thing is. But then we have a formal process. We have an advisory committee. This advisory committee has state, local, territorial, and tribal health department directors, and they come and talk to us around different things. We have 3 different groups. We have a think tank in surveillance, one in finance, and one in social determinants. This group, actually, came a couple of years ago and said, hey, CDC, help us. We, health departments, don't really know how to use and where to find all of the information in social determinants of health. So we developed a website, put it out there, funding went away, so we worked with the University of Wisconsin, and they took it. So we can look at information by county and see what the social determinants and the current available information is. So we respond to the ask of the field in that way. This is the program that I was mentioning earlier, the Public Health Associate Program. We partner with people. We know that we cannot do this alone, so we have contract with the National Council for Behavioral Health, NACCHO, United States Breastfeeding, National Network of Public Health Institutes, and help CDC organize our response in public health through partners, not just through health departments. This is a way that we funnel funds in a more effective and efficient manner. That allows us to be adaptable, flexible, hopefully efficient, we're getting there, but clearly cross-cutting. I don't do HIV, but you heard me looking about HIV today. I don't do opioids. Well, I don't do opioids, but I don't do the opioids program, but you saw how I can put that in the context of what you need to know so we have better actions. So that's what we do. That's what CDC is doing and planning to do for the next several years.
And again, appreciate the opportunity to have our federal partners here today. Corstella Johnson serves as the Regional Minority Health Consultant for the U.S. Department of Health and Human Services. She's attached to the Office of the Assistant Secretary for Health and the Office of Minority Health for Region 7. She's the Regional Minority Health Principal Advisor to the Acting Regional Health Administrator. Her work includes identifying public health priorities and workable solutions for Region 7. So this is really great to have her here as a resource to talk about issues in the region, and also to promote and implement HHS federal programs and initiatives like the National Standards for Culturally and Linguistically Appropriate Services. Ms. Johnson also worked on national initiatives such as National Women's Health Week and Engaging Men in Reducing Violence Against Women, and worked with senior health officials to identify health and data gaps and assess community need. She has a heart for people, and I think many of us resonate with that, and believes in fostering and collaborating and building relationships to impact effective change. Her interests include health equity, health literacy, youth empowerment and development, minority health, and health disparities, and a host of other things. So we appreciate your coming in. Yeah. Thank you very much. Please join me in welcoming Christelle Johnson.
Good morning, everyone. And again, I am Corstella Johnson. Some of you all may know me as Corstella Henley, and I recently had a name change as of New Year's Eve. I had a big, crazy wedding, so I just wanted to just bring that up because I am the same person. Okay? So I am happy to really be here to talk about what's going on here in our 4 states. So without ado, I'm going to go ahead and walk through this because I would love to do questions with you all so we can kind of just talk about what's going on with within our region and what you all are wanting to know more about, okay? So I have been tasked to provide an overview of our department, which is the Office of the Assistant Secretary for Health, also known as OASH. I've also been tasked with highlighting the Secretary's priorities. And then I'm going to close out with a shared dream vision for our heartland region that me and my team, we are beginning to formulate. So let's start here. So here is our fearless leader, Admiral Brett Giroir. A little bit about him, and he's new. He was just recently confirmed in 2018. He is the Assistant Secretary for Health, a former medical school executive and biotech CEO. He has also served in several leadership positions within the government as well as academia, and he has charged us all over the country to lead this opioid efforts, as Dr. Montero has talked about, and so I'll dive more into that shortly. So a little bit about our mission and our public health offices. So simply put, we are here to optimize the nation's investment in health and science to advance health equity and improve the health of all people. Within our office, and mind you, we are also within that HHS structure. We oversee, OASH oversees several core public health offices, including Office of the Surgeon General and the U.S. Public Health Service Corps. Also, we have 10 regional offices throughout the country and have numerous presidential and secretarial advisory committees. It is key to point out within our office, we are considered a division that provides leadership, direction, policy management to HHS. So that's kind of when you think about in a nutshell what we like do as it pertains to our work. Okay, and had to post a picture of our awesome U.S. Surgeon General. I'm not sure if you all have heard. Recently, he was on a plane ride, Delta Airlines plane ride, and he actually, I guess answered this call if there was a doctor on board, and actually helped this man out. And I mean, it's kind of awesome because he is truly, by his title, America's doctor, literally like helped save a life a couple of days ago. I'm not sure the details of that, but definitely look it up. And again, this is our Surgeon General Vice Admiral Jerome Adams. But yeah, I thought that was pretty cool. I was like, I get it. America's doctor. Pretty awesome. And then this is just a map of our 10 regions. And as you can see here, we're in the heartland because we are the heart of the country, headquartered here in Kansas City. And we oversee 4 states, as you all know, because we have representatives from all states here, I believe: Kansas, Missouri, Iowa, Nebraska. So I wanted to just give you a brief high-level overview of the public health offices within OASH. And I think it's also important to show this, because when we start thinking about grant opportunities, right? I know some of you do grant management. Excuse me. Some of these offices provide those grant opportunities. So just taking a look at that. Also wanted to highlight that I was speaking to Miss Louise here, and she was telling me that she works with healthy people. That is actually under our office, and so that would be here, Office of Disease Prevention and Health Promotion. They actually champion healthy People 2020 and soon to be Healthy People 2030. So here on like this slide, I have highlighted a couple of like public health offices, and that's intentional. These offices here that I have highlighted, we actually have regional representation of these offices throughout the country. So yes, here in like your region 7, you actually have a regional rep for these offices. So I am here representing Office of Minority Health. We have someone here for within Kansas City who is the regional lead for Office of like Population like Affairs, and also Office of HIV/AIDS and in infectious disease policy. So I know there was a question asked about work being done here. We actually have someone here who that is their job and tasked with working with each of our 4 states. And so we can dive more into that during the Q&A. So just, keep this in mind, because we do have activities and programs and priorities that are happening here within these areas. And last slide here, and as you can see here, I have here highlighted Office on Women's Health. So as I have shared earlier, we have someone here within our Kansas City office that is your Office on Women's Health coordinator that would be glad to assist you. Here is our awesome team. Some of you all may remember Admiral Jose Bilardo. He has retired, and so our current acting regional health administrator is Captain Shari Jones, and she told me to like share her regards. I am kind of here on her behalf, which I'm thinking of, that's that's great, because like I am awesome and I would love to come and speak to my public health people. So here is our team. Here's who you would be working with and talking to. We do a host of things. Last year, I know I saw some of you all at our public health meeting, Catalyst for Opportunity meeting. But that was one of the meetings we convened our 4 state partners to talk about the Secretary's priorities, talk about what is going on within each state and throughout the country. And so that's just one example of what we like do here. And then also host trainings. We can also serve as presenters, etc. So again, we are your team, so please connect with us. So just I want to briefly go over the HHS priorities, but I am going to focus on opioids. So here are the 3 key priorities: childhood obesity, mental health, and also opioids. So again, I'm just going to focus here for the sake of time, and also because it is a timely topic. So here, just looking at data here that our team has pulled, drug deaths per 100,000 1,000. Now, truly, our numbers do not compare with other regions as it pertains to drug death according to data. But we cannot dismiss that there is something going on here. And it is time for us to really pay attention to those trends. As you can see here, Missouri drug deaths exceed national average. Something's happening, and to be honest, our team did pull this, but we've seen a growth with from, I think it was 2015 up until now. So again, this data is very telling. Prescription opioid overdose deaths. So again, we're seeing this trend, and I wish we had a more, actually I do have one that shows a trend of where we are going, and I'm going to jump to that slide because I think this really brings home that comment that I said earlier. Yes, our numbers aren't as high as others, but we're seeing an increase. I mean, that's just a fact. And yes, Missouri's is really climbing. So it's like definitely time for us collectively to like think about this. And honestly, to even, have the like conversation of, do we really want it to get that bad, right? To the point where now it is uncontrollable. So now we're kind of in a good space here. I mean, not a good space, but in a place where we are seeing trends, and so now we can start talking about, okay, so how can we start seeing a decline? Where can we start the intervention? And this is another good slide about the types of opioids that we are seeing within our, region. And as you can see, we're seeing pretty much equal rates here of heroin and synthetic opioids. Something else to point out is that collectively our data shows us, in terms of drug deaths, meth is like, still number one, that we still need to address that. And I'm sorry that's not articulated clearly here. But again, to really think about that, we do still have a drug problem in addition to this opioid crisis. So, I shared some numbers. I told you this is scary, alarming. So, what are we doing about it? Well, HHS has 5 major priorities. Please take note of these because we will be rolling out more things that are tied into these areas. So, in improving access to treatment and recovery services. So, currently, SAMHSA, you all know about SAMHSA, and I'm sorry, sometimes I get choppy with acronyms too. I didn't want to say it wrong, especially since I'm being recorded. SAMHSA has been championing this and championing it by putting out a lot of grant opportunities to different states to support treatment and recovery efforts. So recently, I think there was over $400 million that was put out there for our 50 states to work on this effort around prevention, treatment, and recovery. And I will say this is just the beginning. More will come out. So if this is a more in terms of funding. So if this is your passion project or something that you've been tasked to do, keep on the lookout on grants.gov for other funding opportunities, because again, this isn't going anywhere anytime soon. Okay? Something else, second priority, promoting use of overdose reversing drugs. So here we're looking at access to Narcan, naloxone. I think here in Region 7, and if you all can help me, I believe now you can actually purchase naloxone over the counter without having a prescription. And I'm not sure, is that for all 4 states? Missouri, I know you can, because I think Hy-Vee, certain Hy-Vees sell it. I'm getting some blank looks. Okay, so I was at a training, a naloxone training, a couple of weeks ago, and it was someone from Missouri and Kansas shared that currently you can now, without a prescription, purchase naloxone over the counter. Is it true here in Iowa too? Okay, so is it for all 4 states? Nebraska? No? Anyone here from there? Nebraska? Okay, well, I like bring it up just so we can talk about the fact, well, just to kind of tie into this point that we are promoting that. Because we know this is a life-saving drug. Now, it's just the first part of it, okay? It's not the end-all, be-all. But I do think it's important to talk about those different policies that are in place. I also think, does Iowa have the Good Samaritan law here? Yes, Iowa has that. I know Missouri. Anywhere else? Kansas? Kansas has it. Nebraska. I'm sorry. Who knows? Who doesn't know what the Good Samaritan law is? Okay, good. I just wanted to end. I'm sure. My apologies. I had to think about that because you never know who you were talking to. But again, so there are processes and programs currently in place. I do encourage you, those that probably don't know, to find out more so that you can share with your clients, with your patients, regarding these opportunities, because truly, here on our end, HHS's end, we are wanting to ensure that people are getting access to this, promising drug. Okay, last 3 priorities, because I can go on and on about each of these. The third one, strengthening our understanding of the epidemic through better public health surveillance. Dr. Montero talked about CDC's role in really championing this. Also, we have the enhanced, state opioid surveillance program, which is also putting out grants and also offering trainings to assist states and local authorities in monitoring and tracking this epidemic. And so again, trying to really improve our efforts in terms of what this is looking like throughout the country. And the last two are looking at pain and pain management. Our office, OASH, released the National Pain Strategy, and this is in partnership with NIH to provide some evidence-based, excuse me, my apologies, evidence-based pain management tips, tools, and activities to help local governments and healthcare providers address pain. And I did not put a link to it here. I can send it to you, Jean, and you can send it out. But it's a long document. I do encourage you to take some time, maybe over the weekend, and read it. But again, these are just some of the things we're doing within our office, within HHS. Regionally, I want to highlight this really quickly because so now that's, we just talked about the 5 major priorities for HHS. So what are we doing here? Excuse me. So the Office on Women's Health put out a grant, and Iowa Department of Public Health, Division of Behavioral Health, were the recipients of this grant, and this grant looked at opioid misuse in women. And so here, the Iowa Prevention of Opioid Misuse in Women program is a 3-year grant awarded to Iowa to expand the prevention strategies that support the decrease of opioid misuse in women. And so they're actually working closely with our regional women's health coordinator on this effort. So yes, this is going on in your backyard. Another thing we're doing here is that Region 7 HHS have formed an opioid task force. And this task force, we also work with our regional partners to really look at this epidemic, look at how it is, impacting our communities, and also trying to identify ways to really address this within our region. So this is just a few of those efforts that we're doing at the regional level. So I want to end here. I have 2 more slides, and I wanted to end with the regional shared mission and vision, which is still in its genesis. Okay, we're still formulating what this is going to look like, but actually this came out of our Catalyst for Opportunity meeting. Captain Shari Jones posed a question last year at our meeting in terms of what do we want our region to look like? What do we want it to be known for? And that was a pretty, I would say, loaded question and, heavy request. But a few people responded to that in terms of something along the lines of being the healthiest region. And I don't know who it was who said it to her, but she held on to that, and she is wanting to see that through. So I'm not sure if that person's here. Thank you for adding to our workload, but it's exciting. It's exciting. It's exciting. So as you can see here, here's what we're wanting to do. Excuse me. Advance health equity among existing and emerging populations and become region in the country. That's what this is saying here. And so we have talked about how would this look, how do we make this happen? And it all came down to us needing you all's help and expertise. Because it really is going to take a collective effort. I mean, we can sit here and quote data upon data about what's happening, right? We know that we have life expectancies are declining. And we are seeing that connection with the drug deaths, increase in drug deaths. We know that our country is shifting, right? We're becoming more and more diverse. I think at like one point it was said that we would be a majority by 2050. We're already on trend and seeing that happening even sooner. Just within our region alone, we went from being, even though we are a predominantly white population region, we've always had more, I think it was data to say 20% African American. We're seeing that decline and shift, and we have a growing Latino population. So we're already seeing the dynamics. And so as we see these changes and as we, hear more about what's going on, and I would be remiss, and let me look at my notes. In Kansas and Missouri, we recently dealt with a measles outbreak, right? In 2018, measles outbreak. So, again, I could jump on because I have a lot of notes, but I don't want to. I really want to have a conversation with you all, and honestly, I will be calling and knocking on doors because that's what I do best, asking you to really help us talk about, so how do we start this process? Because we need your help. Some of you are already doing this work. So the question, because from our standpoint, we want all 4 states to be healthy and to be the healthiest. So your help is needed. And so just know this slide is more so my pitch to you to help us. I will end here with this slide. This is just to show there are several public health theories and models, but this is just one to show you how we can get to where we need to go. Neither of these levels are mutually exclusive. It all comes together. It takes it all. So with that, I will end with this. Follow us on Twitter, because since I just told you all that has been, sent to me to do. Also, I don't have business cards because, again, I'm going through a name change and in government. I don't know when they'll know me as Corstella Johnson. It may not be till 2019. But please take down my contact. People know I do answer. I do respond and call people back. So please contact me. I'm a very personable person. So thank you for this time.